All right, let's get right into it. Welcome to this explainer on the tragedy of the immoral protein, scattering and turbidity in cataracts. We are about to embark on a fascinating biochemical journey straight into the center of the human eye, specifically the crystalline lens. We're going to explore exactly what happens when the proteins that give us our window to the world actually begin to age. There is this super common misconception out there that a cataract is just, well, a cloudy lens. Let's debunk that right out of the gate. Cataracts are not simply cloudy lenses. They actually represent a progressive, incredibly complex disruption of a highly ordered optical structure. As that transparency goes down, light doesn't just hit a wall and get blocked, it gets scattered. And that scattering is exactly what produces the glare, the reduced contrast, and the blurred vision that patients actually suffer from. Understanding this is a massive paradigm shift in how we think about eye health. Okay, let's dive into this. Here's our roadmap for the explainer. First, the myth of cloudy lenses, followed by light scattering and proteins. Then we'll look at the aging lens nucleus, how clinicians quantify cataract density, and finally, the difference between forward and backward scatter. Section 1. The myth of cloudy lenses and the perfect optical structure. Before we talk about how things break down, we really need to understand the eye's pristine, normal state. The normal crystalline lens is an absolute marvel of biology. It is a highly concentrated, precisely organized structure of long-lived crystalline proteins that ensures near-perfect transparency. It's a bit like flawlessly stacked glass. But here is the most mind-blowing part. These central lens proteins are virtually immortal. The fibers in the lens nucleus are laid down before you are even born. They lose their organelles, and they have basically zero protein turnover. The proteins you have sitting in the center of your eye right now, they are exactly as old as you are. Moving right along to Section 2, light scattering and proteins, or the biochemical breakdown. Let's zoom in to the microscopic level. Now, what's really interesting here is this inevitable domino effect. Because these proteins never turn over, they just accumulate damage every single day. Progressive oxidation causes these incredibly stable proteins to unfold, which exposes these hidden sulfhydryl groups. Oxidation steps in again, converting those newly exposed groups into disulfide bonds. This literally forces neighboring proteins to cross-link and clump together into massive molecular tangles. Think of it like clear liquid egg whites turning into a solid, opaque mess when you fry them. Those aggregates are what physically scatter and absorb incoming light, progressively ruining the lens's transparency. And actually, it doesn't even stop with simple oxidation. These proteins are subjected to a constant barrage of chemical wear and tear. We're talking about glycation, carbamylation, acetylation, methylation, deamidation, and calcium precipitation. Everyday realities like diabetes, sun exposure, and just normal aging create a perfect storm that drastically accelerates these structural modifications. Which brings us to Section 3, the aging lens nucleus, a lifetime of scars. Let's pan out and examine the macroscopic result of all this damage, specifically nuclear sclerosis. 50. That is the magic number. From a biochemical perspective, before you hit age 50, only a very tiny fraction of your lens proteins are actually insoluble. Up until this point, despite decades of living, that pristine optical structure actually holds up remarkably well. But then, watch how dramatically the story changes. By the time someone reaches 80 years of age, up to 80% of the proteins in the lens nucleus can become completely insoluble. 80%. That is a staggering accumulation of lifelong oxidative injury. And this increasing insolubility is the exact biological driver behind lost transparency and senile cataract formation. So what does this actually look like as it's happening? Well, as those massive protein aggregates develop, biochemical reactions generate brown pigment right inside the nucleus. The lens goes from brilliantly clear to slightly yellow to more intensely yellow into a deep brown and finally to an increasingly opaque state. It's just a steady, visible march of molecular accumulation. But here is a fascinating, almost paradoxical twist in that progression, known as the myopic shift. Because new lens fibers are produced throughout your entire life, the older original fibers get compressed centrally. This compaction increases the density of the nucleus before it goes totally opaque. And because this alters the refractive properties of the lens, patients might actually notice a temporary improvement in their near vision. It's this brief, unexpected perk, often referred to as second sight, right before their overall visual quality takes a significant dive. All right, Section 4, quantifying cataract density through objective measurements. Dealing with a hardened, heavily cross-linked brown nucleus makes modern cataract surgery, phacoemulsification, technically very demanding. The denser the nucleus, the more fragmentation power the surgeon needs. So how do ophthalmologists objectively measure this damage beforehand? They rely on clinical tools like the slit lamp examination, which lets them differentiate between nuclear, cortical, and posterior subcapsular morphology. The optical principle underlying the slit lamp relies entirely on scattered light, visualizing the light bouncing back from the lens. Clinicians can even use densitometric analysis of these photographs to track progression objectively over time. Section 5, Forward versus Backward Scatter, the final duality. This is the crucial physical distinction between what the patient is suffering through and what the clinician is actually seeing. And this brilliantly illustrates the disconnect. You've got the patient's view, which is dominated by forward scatter, light hitting the dense protein tangles and scattering forward onto the retina. This degrades image contrast and creates blinding glare, especially from headlights at night. Then you have the doctor's view, which relies on backscatter, the scattered light reflecting off the cataract and bouncing back toward the slit lamp. Two totally different perspectives of the exact same problem. Let's look at how this plays out with different types of cataracts because it highlights a major paradox. With nuclear cataracts, there is substantial backscatter, so the doctor looks in the slit lamp and easily sees a dense, highly visible cataract. But consider a posterior subcapsular cataract. These might produce very minimal backscatter. To the doctor, it might look relatively mild. Yet because of its location, it generates severe forward scatter, practically blinding the patient in bright environments. A patient's visual disability can feel far, far worse than the clinical appearance might suggest. Which means, ultimately, clinical management is based on the functional impact on the patient's quality of life, not solely on measured density. You can't just treat a number. Surgery is indicated when that scattered light, specifically that forward scatter, truly disrupts the patient's daily life and independence. So, we've covered the whole journey today, from pristine transparency to microscopic tangles, right down to the clinical reality of scattered light. Knowing your eye's immortal proteins never turn over from the time you were born, how does understanding light scatter change the way you view the biology of aging? It certainly makes you appreciate the incredible yet fragile engineering of the human body. Thanks for joining me for this explainer, and keep asking questions.